teacup appearance or piece of pie in keeping with lunate dislocation. So I would like to see for any association of the scaphoid fracture in this film, in which I would do a scaphoid series to see any association with the scaphoid.
Is this lunate or perilunate dislocation?
This is a lunate dislocation.
Why do you say it's a lunate dislocation?
Because the appearance of the capitate lunate should be on top of the capitate. So the capitate is dislocated from the.
Is the lunate in the normal position?
Lunate is normal.
Yes.
The capitate
So why do you say
dislocated.
why do you say it's a lunate dislocation? The lunate is in its normal position.
Anda ni. Macam mana ingat ni? Kita ingat ni.
Sorry. Should be.
Kita jawab ada ni. Sorry je tinggal. Ada kata nyesah.
Come on, those who are not talking, please mute your mic. It's too much interference. Okay, so that is the radius. That is the lunate sitting on top the radius. So the lunate is not dislocated. The capitate should be sitting on top of the lunate. There should be radius, lunate, capitate, and the metatarsal all in one row. But now the capitate is gone back. So this is a lunate or perilunate?
So it's a perilunate.
Yeah, this is a perilunate dislocation.
Perilunate.
Nothing. Or just look at the lunate. Lunate is sitting on the radius means it's not the lunate dislocation. Okay.
Okay.
Because all these dislocations, you want to make sure there's no scaphoid fracture. More common, the lunate or perilunate? Scaphoid fracture more common, the lunate or perilunate dislocation?
Not sure about that.
Is that called a
perilunate?
Trans-scaphoid perilunate dislocation? Isn't that how it's said?
Yes.
Okay then. Okay, come next.
Okay, this is the frontal chest radiograph of adult patient. There is dextrocardia of the heart, and then there is reticular opacities seen at the bilateral lower zones. There is no lung nodosis. There is no consolidation of cavitating region. The lungs and bones. There is no perforation. Okay, so my question would be dextrocardia with left the lower zone opacity. My differential would be Cartagena, and also the situs inversus.
Okay, so okay, you are reporting your normal radiograph every day. You're sitting in your room, and this pile of X-rays comes, and this is one of it. What is the first thing you would do?
First thing, looking at the marker, lungs.
Yes, okay. First thing you want to do is make sure the marker is placed properly, okay? All right. Otherwise, you're just making a wrong diagnosis on the wrong person. Okay. So that's just to let you know that's what they will test you on in the Viva. Okay. How you work. In everyday, first thing you want to make sure the marker is correct, right? In your chest X-ray, especially in cases like this. All right? Because it makes a lot of difference. Okay, so now assuming that the marker is correct, you went and check. Okay, it's fine. Right? So you notice there's dextrocardia, and you also see this tubular and cystic opacities. So that is due to
Due to a bronchiectasis.
bronchiectasis, okay? And there is associated situs inversus because gastric bubble is on the right side, okay? So all these will point towards Cartagena syndrome, okay? Okay, next question is the heart otherwise normal besides the electrocardia, or there's some cardiac abnormality as well?
The heart is normal in size and
No, in
the-
Cartagena syndrome, is there an intracardiac abnormality, or is just the dextrocardia only, or both?
mm, um, I'm not sure.
Okay, the heart is otherwise normal, okay?
Heart,
Except for the dextrocardia, there's nothing else wrong with the heart. All right. So most times when there's dextrocardia with situs, please mute your mics if you are not talking. Okay, thank you. If there is dextrocardia with situs inversus, the heart is normal. Okay. If it is dextrocardia but there's no situs inversus, then highly likely there's something wrong with the heart as well, right? So what is the primary pathology here?
primary pathology is the bronchiectasis because of there is mucociliary dyskinesia is caused stagnant of the mucus and also causes
It's a mucociliary motility disorder, okay? So, and the male patients are what? They are?
male usually is problem with infertility
Because?
because of the seminiferous this dyskinesia of the this motility of the sperm.
Yes, okay, yeah, sperm can't swim, okay, because the tail, the there's motility disorder, so it cannot swim, all right? So they become infertile. It's not that the volume is less, it's just that it doesn't move, okay? So that's a bronchiectasis that if you want to do a CT.
Okay.
Okay, let's go on to the next. Okay, come.
Hi, Dato'. I'll try this film. So this is a chest radiograph frontal projection. Okay, I'm looking through the radiograph. So the lung parenchyma is unremarkable. Heart borders are clearly visualized. There are no retrocardiac opacities. The trachea shadow at the cervical region appears narrowed. Otherwise, there are no other significant abnormality in the bones. Okay. So I would like to give a diagnosis of acute bronchiolitis due to the steeple sign.
Okay. So, yeah. Okay. So you notice the steeple sign, or looks like a champagne glass. Okay. Champagne glass like that. All right. So that is. It just means that the trachea is narrowed, so there's inflammation of the trachea, and that's typically seen in what disease?
Sorry. Acute bronchiolitis. Epiglottitis, sorry.
No.
What disease? Sorry. In croup.
Yes, and that is laryngotracheobronchitis. Okay.
Okay.
Is seen in crew. That's right. Okay. So that you just have to say this can be seen in crew, and just find out if the patient has what kind of cough they have.
Barking cough.
Yeah, like a barking cough. See, that's what you must do. You must do a bit of clinical presentation. Then you present it back to the examiner, or if you are reporting this, then you want to find out if there's such a history exists. You see. All right. Okay, fine.
Do that.
Okay, next.
Kita unmute dulu. Okay. This is a frontal pelvic radiograph of an adult patient. So from this radiograph, I can see that the bilateral sacroiliac joint is unremarkable. No narrowing of the joint. Apart from that, the bones are normal. I can see that there is a cortical discontinuity at the left anterior superior iliac spine, and with some minimal displacement of the fracture fragment. Apart from that, I don't see any other fracture over the visualized bones. The bilateral hip joints are also preserved. There is no abnormal mineralization of the bone. So my diagnosis is the fracture of the superior inferior iliac spine.
I've not heard of a superior inferior iliac spine.
Anterior superior iliac spine.
Okay, fine. Okay, so how did this fracture happen?
Fracture might be because of the avulsion fracture.
Yes, this is an avulsion fracture. It's not a direct trauma fracture. Okay, so what has avulsed it?
The muscle which is attached to this part of the bone is the sartorius muscle.
Yes, okay. So this is it is the avulsion fracture at the sartorius insertion. Okay. All right. So in the exam, they may ask you all certain places where avulsion fractures occur. Right. So you need to know what is attached in that particular places. Okay. Base of fifth metatarsal, what is attached?
This metatarsal.
Fifth metatarsal.
Fifth metatarsal. Peroneus muscle.
Yeah, peroneus what?
Peroneus longus. I'm not sure, Prof. I think it's the peroneus longus.
No, it's the brevis. Okay.
Yeah, brevis.
Yeah, the brevis is the shorter one because joint there. Longest goes further in front because it's long. Okay. That's why it's called longest. Brevis means short. Right?
Okay.
So like that, there are different other places. So you need to know if you see an avulsion fracture, you can say it's an avulsion fracture and say what they will ask you what muscle is attached there, what tendon is attached there. All right.
Okay, Prof.
Okay, next.
Hi, Prof. Tong here from UM. So this is a frontal radiograph of an adult patient, frontal chest radiograph, and I can see that this patient has done has a history of a sternotomy with sternotomy wires at the frontal chest. There is a lobulated opacity seen at the area of the, I think this is at the area of the posterior mediastinum, as I'm able to visualize the hilar vessels. There is no obscuration of the left heart border, and there is obscuration of the left paraspinal line. There are also several linear opacities at this area in keeping with surgical clips. In addition, there are some reticular opacities also at the right behind the retrophrenic region, and overall, I think this is a left-sided posterior mediastinal mass, and with the patient's history of what looks like a bypass, this patient might have some cardiovascular risk factors. So my provisional diagnosis would be a thoracic aortic aneurysm or a dissection. So I would like to correlate with the patient's clinical symptoms, and if suggestive, would like to proceed with a CTA aorta.
Okay, fine. So this is a case of a mediastinal mass. So we have gone through a few mediastinal masses. We looked at lymph nodes, and there are others, the common, all the T's. Okay, so esophagus is one of it in achalasia. Another one is vascular causes like aneurysm. Okay, so these are all the possible causes of widened mediastinum. And rarely another one is extramedullary hematopoiesis. That also will look like a posterior mediastinal mass. So we see which one fits best, and then you want to do a CT, and you can get a CT done. Just a moment. So that is the thoracic aortic aneurysm. Okay.
Okay, thank you, Dato'.
All right. Okay, next.
Okay, Prof. Rusli here from USM. So this is anchor. Okay, so this is anchor radiograph in AP view. And okay, so on the right side, this is, I think, a magnified image. Okay, so looking at the image, I'm looking for the abnormality, but now I didn't find yet, but I'm assessing the image. Looking at the bone, at the distal tibia, there is no obvious abnormality. And for the distal fibula, also I don't see any obvious lesion. the cortex is intact, no fracture seen of the tibia and fibula, and the ankle joint appears there is no dislocation. The clear space is normal, and assessing the tarsal bone, yeah, actually I can see, I think there is a misalignment of the tarsal bone. Telo. Okay. I think I see this misalignment of the tilo, this one.
Okay, this is an AP view of the ankle. Okay, what are the bones that is clearly demonstrated on this view? What are the bones?
So the talus, distal tibia and fibula.
Yes, okay. So you said that distal tibia and fibula are normal. What about the talus?
Oh, I can see there is some lucency at the right superolateral aspect of the talus. Some lucency there, but the cortex also appears quite irregular there at the region of lucency. And this lucency has a narrow zone of transition with sclerotic margin medially. Apart from that, there is no obvious periosteal reaction at this region. Okay, however, the joint space at this region comparing to the lateral side is the joint space appears almost regular. There is no narrowing. And then assessing the rest of the bones, I don't see any other findings. And regarding the soft tissue at this region, there is no obvious swelling. So I'm thinking my differential diagnosis because of the lucency with surrounding sclerosis. So I'm thinking of osteonecrosis of the talus bone.
Okay. So what's the name given here? Yeah, is the pathology is osteonecrosis, but it's
osteonecrosis. Usually because of the disruption of the blood supply to that region that causing the osteonecrosis.
It's called osteochondritis dissecans, the name given to this, okay? Okay. So you can see the same thing in the knee as well, osteochondritis dissecans in the knee, okay? The common place is in the lateral surface of the medial femoral condyle, right? Okay, somebody shout the diagnosis.
Osteonecrosis of the navicular bone, AVN of the navicular.
What's the name?
Cochlear disease, Prof.
Yeah, okay, cochlear disease, okay? So again, the exam, all the AVNs that occur in different bones, if there's a name to it, just you have to know that and say this is what it is, okay? It's just a spot diagnosis, maybe a warm-up film, the first film or something, right? Yes. Let's see. Okay, so we can skip. Complicated. Okay, let's move on. Now we're coming to the more exciting exam type cases. Okay, come next.
Dato' Ashikanya from UM. So this is a right hand X-ray in front of you. So I can see there is a multiple punch out lesion at the metatarsal fifth at the head, and then also at the proximal phalanx fifth, and also at the second proximal phalanx. This punch out lesion also has overhanging edge. Otherwise, there is associated with the soft tissue calcification adjacent to it. Other than that, the rest of the joint space are unremarkable. At this point, my differential diagnosis will be gouty arthritis with tophi. Next, I would like to correlate with the serum uric acid to confirm my diagnosis, and
Yeah,
also
okay.
look for the foot radiograph.
Okay, fine. So you said one of the diagnoses you consider is gouty arthritis, right? Tophaceous gout. What other diagnosis would you consider?
The diagnosis, it can be also can it be osteomyelitis also because of the lytic lesion?
No, no, okay. So I'm trying to tell you this because sometimes in the exam there's no differential diagnosis. This is typical, almost pathognomonic of gout. Okay, so you should be confident enough and say this is this appearance of tophaceous gout or gouty arthritis with tophi. There's no other diagnosis that fits this. Okay, so because it punched out juxta-articular erosions in different joints associated with the dense soft tissue calcification. If I describe that to you, it's gout and nothing else. All right. So you must be confident also in the exam that sometimes it's just that one diagnosis, it's like a spot diagnosis, it's nothing else. So why you say osteomyelitis in different joints? Does it happen? Osteomyelitis or infection is usually one joint, right? Typically, when you have a septic arthritis from infection, it's one joint involved, right? Not multiple joints like this. And the clue is it's juxta-articular means not at the joint. The ones at the joint are rheumatoid arthritis. This is juxta, you see, it's away from the joint. The joint is there. That's why it's called a juxta-articular erosion, right? Okay, and rightly, like you say, you just check with the serum uric acid level, right? So the exam, sometimes the first picture or second picture is a straightforward case. Must be confident enough to say this is gouty arthritis, and that's it. Stop there. All right. Let's see, what is this? Just a moment. Let me see if it's something worth discussing. No, I think I can skip this.
That was sorry. This on the hand X-ray.
Yeah.
Is it two diagnoses there, or just
No,
gout?
just tophaceous gout. That's it. Tophaceous
I
gout
see.
is gouty arthritis. Tophaceous gout means there's
Okay.
tophi, the soft tissue, dense soft tissue mass as well, forming tophi. You see.
Okay.
Okay, come.
Izian here from USM.
Yeah.
So this is the intravenous urography in the excretory phase. I can see there's presence of complete duplex collective system. Sorry, there's duplex collective system seen bilaterally. On the right side, I think it is complete. However, on the left side, I cannot really delineate the distal part of the bilateral ureter. It is associated with the hydronephrosis of the left upper moiety. The urinary bladder is well opacified. Its presence of rounded lucency seen within the urinary bladder likely represent the cobra head sign. So my provisional diagnosis will be the bilateral duplex collective system. So that's all.
So your diagnosis is bilateral duplex with the presence of what on the left side?
The left side,
Why is the left upper moiety dilated?
Usually in the weighted yellow, the upper moiety will be associated with urethrosil.
Yes, okay.
While the lower one will be associated with reflux.
Yeah, okay. So the moment you see duplex, you want to look for whether it's dilated or not dilated. Number one. Number two, you want to see if there is any what happened here? Any urethrosil, okay? See if I can get. Everything is gone now. Never mind. Okay, so that's all about duplex. Remember, you always want to do a what scan together with the duplex? What scan would you do? If you saw this dilatation and you don't see the urethrosil, what would you do? All pediatric patients, you want to do what?
Ultrasound, bro.
Yes. Yes, ultrasound is excellent. Okay. You always do an ultrasound when you see a duplex system because you may not see the urethrosil, but ultrasound may show the urethrosil. All right. So sometimes you don't see excretion in the upper moiety because it's completely obstructed. Then when you do an ultrasound, you'll see the duplex. One is markedly hydronephrotic, so not excreting. So always when you see duplex systems, combine it with an ultrasound. Sometimes they show you an ultrasound only and then move on to an IVU sometimes, okay?
Okay.
Okay, next. I tell you, I think we'll skip this because I doubt you'll be asked small bowel follow through anymore in your exams. So don't waste time there, right? Okay. See if I can get this. Okay, come next.
Good evening, Dato. I'm Raymond from UM. So this is the axial slices in porous venous face of the CT abdomen in multiple slices. So at first I can see there are multiple right renal cysts, but the left kidney is absent. Otherwise, I don't see any free fluid within this slice or any fat stranding in the peritoneum. And looking at the pancreas, the pancreatic head is bulky and bulky and is enhancing in the venous face. And so the provisional diagnosis in this case is a renal cell carcinoma, could be with a metastasis to the pancreas. So I will review other phases of the CCT abdomen pelvis to look for the artery enhancement of the pancreatic head lesion, which could be a metastasis, because the renal cell carcinoma is a hypervascular lesion.
So where was the renal cell carcinoma? You're saying it's from the left side?
Yeah, because it could be a history of the nephrectomy of the left side.
I see, okay. You have been in radiology, what, now 3-4 years? Am I right?
Yeah.
Yeah, okay. Have you seen a metastasis to the pancreas?
Yes, I've seen one.
And how common is it?
Quite rare. It's very rare.
Extremely rare. Okay, fine. Now, if you have a lesion in the pancreas and you have a lesion in the kidney, what bell will ring?
Pancreas and the kidney could be associated with some kind of syndrome, von Hippel-Lindau syndrome.
Yes, yeah, that's what you should say this is, okay? Right? Because the other kidney is also not normal, right?
Yeah,
so
the other kidney is
things
normal.
going on. It's a systemic problem that's going on. You get a pancreatic lesion, you get a kidney lesions. So always in the exam, if there is multiple findings, always think in the back of your mind, can this be part of a syndrome? Okay? Because you as a radiologist may be the first person to highlight to the clinician, they look for von Hippel-Lindau, all right? Because they may be seeing isolated abnormalities, but you as a radiologist, you're looking at the whole picture, and you can actually highlight to the clinician, this may be von Hippel-Lindau, say. So like anywhere, if any film you're given and the word von Hippel-Lindau comes out, what must you do?
I would suggest for the MRI brain to look for hemangioblastoma.
Yes, okay. So it doesn't matter if they show you a brain and you see a disease or lesion that looks like a hemangioblastoma, you also want to highlight to the clinician to make sure at least do an ultrasound of the kidneys. All right, because this may be part of the syndrome. Okay. Likewise, either way. Okay. So remember the exam, some of them are like this. They are part of a syndrome. So if it is part, it must click in your mind straight away, right? You saying metastasis from the left kidney renal cell carcinoma to the pancreas is such a rare thing. and you forgot that the other kidney also shows lesions. So then you must already start thinking, can this be part of a syndrome? All right.
Yeah.
Okay, one he put it down.
Thank you, Dr.
Such a rare disease, but very common exam question. I wonder why. Okay, let's see. I think we'll skip this. Okay, this one, I just again I doubt you'll be shown this or you'll ever know, but just as an interesting case, that's a large mass in the spleen, cystic with a thick calcified wall and multiple small calcifications swimming inside. Anybody knows what this is?
Yang itu bunga teratai.
It's a lymphangiomyomatosis.
No.
Hydatid cyst.
Yes, this is hydatid cyst. This is the mother cyst and all the daughter cysts inside. Okay, so all the scolex, that's why it's calcified. Right. So the mother cyst and the daughter cyst. I always question why is it that mother and daughter, not son and father? Anybody knows?
Apparently men not important.
Yeah, maybe you're right.
Men cannot give birth. Yeah.
Possible, yes. No, I don't know. I'm just thinking out loud. Okay, next.
Okay, Abu from USM. Given to me is a frontal chest radiograph of an adult patient. Okay, there is homogeneous opacity seen at the right hilar region, which obscuring the upper part of the right heart border. And the medial part of the opacity is not well outlined, which is give the obtuse angle to the lung. Then there is no calcification within the lesion. The lung bilaterally it is relatively clear. There is no focal lesion within the lung itself. And reviewing the hidden areas, there is no other significant finding. The bones and also the soft tissue are remarkable. So from this radiograph, my ratio will be the anterior mediastinal mass. So the differential will be could be thymoma. And
okay, so you saw a lesion here. Is it only on this side or is it on the left side as well?
Oh, sorry, I just noticed that over the left side also have the paravertebral homogeneous opacity also.
Yeah, so now where can you localize it? Where do you think it is?
It is at the posterior mediastinum.
Yeah, okay. So what's your possible diagnosis here? Differential diagnosis you'll consider at this moment?
For the posterior paravertebral, it would be extramedullary hematopoiesis. However, the bones itself, I'm not really can appreciate whether the patient have osteopenic.
Again, it's such a rare condition. You all think of the rarest first. Think of the common things first. Okay, like what?
Can be tuberculosis.
Yes, of course. Yeah, tuberculosis with abscesses. Yes.
Other than that, it can be duplication cyst.
Duplication cyst you won't get on both sides, right? So what can involve the spine and you can and there's a mass? You think of infection, yes. What else besides infection?
The nerve sheath tumor.
Pardon?
The nerve sheath tumor, peripheral nerve sheath tumor.
Again, they don't tend to be on both sides. You get one nerve coming out on one side, right? What other tumors? Like what?
Neurofibroma.
Oh, again, that's not bilateral. It's from the vertebra. What would you think it is? Commonest bone lesion is what?
Bone metastasis.
Yes, of course. Metastasis with an extra osseous soft tissue component. When you say metastasis, you can also say the word. What other tumor? Myeloma as well. Okay. Right. So now you think these are the possibilities. All right. So important negative to say there's no evidence of pulmonary TB. Am I right? Because you're thinking of TB, you know. If this patient has TB in the apices, then you'll be suspicious that this is tuberculous spondylodiscitis with abscess, right?
Yes.
Okay. So you must think like that. Think laterally and think what the possibilities. So what would you do next in this patient?
I would like to review the MRI.
Well, maybe you want to do. So I've got a plain CT here. I'm not sure how well you can see it, but can you see the abnormality?
It's the opacity at the paravertebral region over the left side.
Okay, and what happened to the vertebra?
Actually, there's destruction of the vertebra.
Yes, yes, collapse and with destruction. So the plain X-ray tells you it is from the vertebral body, right? So again, there's a compression fracture causing the gibbous. Okay, when you say the word gibbous, you're thinking of
TB.
Yes, okay, right? So this is how you describe these things. Okay, now you want to say you want an MRI, okay? So I don't have an MRI, but this turned out to be TB with a tuberculous abscess, right?
Okay. Okay, ma'am.
So again, posterior mediastinal masses, another cause of it, all right? Okay, next.
So I'm here from I'll give it a try. So I'm presented with the CT scan of in axial sizes at the level of the pelvic boot. So from the plain scan, I can see that there is an irregular mass occupying the left side of the abdomen with ill margin border. This mass enhance homogeneously and with causing mass effect and displacing the loops of the small bowel, to the medial side. Otherwise, the visualized abdominal aorta appears patent. I could not see the left kidney as well. So
This
in
is below the left
conclusion,
kidney. The left kidney is fine.
Oh, sorry.
Left kidney is okay.
Yep. Okay. So in conclusion, this mass is arising probably from the retroperitoneal area. So my diagnosis, my provisional would be a nerve sheath tumor or a retroperitoneal metastasis.
Okay, so I know this is just spot images, difficult, but in the exam you'll be given a stack, so you'll know where it comes from. But never mind, just to test your thinking. What about the image on the left side?
On the left side, it's at the level of the kidney with visualization of the liver. So at this
Sorry,
at this level,
on the left side,
oh,
you see
on the
another
left, sorry.
image, right? Yeah. What is the
Yes.
image showing you? What window is that?
This is in a bone window.
Yes.
So there
okay, now
is
have a look.
an involvement of the bone with areas of lucency and lytic within the iliac bone over mainly over the left side, but involving the right iliac wing as well. So this might be a lytic bone metastasis.
You say the bone is lytic. Don't you think the density is high? There are patchy sclerotic areas.
Yes, there are patchy sclerosis, and I think there are areas of hypodensity as well.
Okay, fine. So now with that finding and this big mass, like you say, what's the possibility?
It can be originating from the I think the bones are as a result of metastasis. The mass itself is probably can be arising from the spleen, causing a splenomegaly or
Yes, okay. So you think that maybe a spleen?
Can it be a myelofibrosis?
Yes, of course. So you have a big spleen with sclerotic bones. Yeah, myelofibrosis is what you think of. Right, yes, spot on diagnosis.
Yes.
All right. Okay. So if you're not sure, what do you think the clinician will do the next test? You'll say you want to correlate with what? Hematological parameters, right?
Yeah,
Then you say
hematological because of the involvement of the spleen. We'll proceed with the bone marrow aspiration.
yes, in myelofibrosis, you get pancytopenia and you do a bone marrow aspiration. How will the tab be? What will they get?
This one I'm not sure.
Nothing. It'll be a dry tab because the whole marrow is sclerosed. Okay. So when they do a bone marrow and it's a dry tab, then you're already thinking of myelofibrosis. All right. See, although you are a radiologist, but you must know these things. Okay? If the clinician tells you the history, patient came in with gross splenomegaly, pancytopenia, and bone marrow aspiration was a dry tap, you straightway will think of myelofibrosis.
Fibrosis,
Yes, purely by the history. So although you're a radiologist, you need to know these things. Okay? Yes, because you also learn the diseases, right? Every disease you know a bit. Because remember, we radiologists, we are jack of all trades. We need to know a bit of everything, and we are master of one, and that one is radiology. So remember that you need to know a bit of everything. All right?
All right. Thank you, Dato'.
Okay, just a moment. Just give me a minute. Yeah, let teaching day. Just text me. I can have a look here. Okay, come. Let's go on to the next case. It's the BQ scan, which is hardly done nowadays, so we can skip that. I don't know what is this.
Mariam from USM. There's a well-defined soft tissue dense.
Yeah, just a moment. There's another image coming. Too many. Let me just see which is the same. Okay, come.
Okay. So these are selected as the images of a CT abdomen. There is a well-defined homogeneously enhancing soft tissue mass seen at the posterolateral aspect of the left abdomen. This mass has clear plane of demarcation with the paraspinal muscles as well as the lateral abdominal wall muscles. It is associated with minimal surrounding fat streakiness. Constellation of findings could represent soft tissue sarcoma. I would like to review the rest of the images to see the extension of the mass.
Okay. So what are the possible types of sarcomas you know there?
Liposarcoma. However, in this image, I cannot see fat density within the mass.
Okay.
Other than that, if this is a pediatric patient, rhabdomyosarcoma.
Okay, possible, yes. Anything else?
Other than that, no idea, Prof.
Okay, fine. So this is in the abdominal wall, right?
Yeah.
Okay, fine. What if I told you this patient has repeated endoscopies and things for multiple polyps? So what do you think of?
Pearce-Jaeger syndrome?
No, together with this mass.
Together.
That's what I'm trying to tell you, it's part of a syndrome. What is it?
Gardner syndrome?
Yes, yeah, Gardner syndrome. Okay? Gardner syndrome is you get a familial polyposis, and what mass is this?
Tak ingat apa.
Is it a rhabdosarcoma? Is it a liposarcoma or what? What's the name of this tumor? No idea. It's a desmoid. Yes, the desmoid tumor. Okay. So this turned out to be a desmoid tumor, but so that's a differential diagnosis in this case. So in the exam, they'll ask you that, you know. It'll give you a history, especially a history of polyposis, and you need to tie the two things together, right?
I see.
So this is how the Viva will be. It's not just straightforward looking at a mass and saying, okay, this looks like a sarcoma or a soft tissue mass or a mesenchymal mass. It'll be something more exciting, right?
Okay.
So remember syndromes, and it must click when the examiner tells you that, okay? Okay, now we have gone through this, so now somebody who's doing this should get it right. Okay, who want to try?
Datuk, this is Eugene from UM. Here's an image of a IVU in the excretory phase. Should there is the right and left renal pelvis with contrast filling into the ureter down to the urinary bladder. There's no hydronephrosis or hydroureter. There is some narrowing at the left proximal ureter.
How old is this patient?
He's a relatively young.
Yes, okay. Now you must start already thinking, why is a young patient getting an IVU?
Most commonly, it's look for reflux or obstruction.
As seen in what case?
Either reflux condition or duplicated collecting system.
Yes, okay. Now you want to start thinking, can this be part of a duplex collecting system? Have a look again.
Maybe on the left, there seems to be two ureters.
Okay, fine. Yes, okay. So see part of a second ureter there. Okay, yes.
And there's also opacity at the pelvic, at the cycloureteric junction, in keeping with the urethral seal.
Yes, okay. Yes. So the urethral seal is associated with upper or lower moiety?
The upper.
Yeah. Do you see an upper moiety?
No, not seen in this case.
You see a faint dilated upper moiety here. See? Delayed excretion because obstructed, because there's two ureters here. See, there's ureter there, right? So it is excreting, but it's delayed and dilated. Okay. So now you know on the left side, there's a duplex collecting system with obstructed upper moiety and a urethral seal. Okay. What about the right side? Normal?
The right side, the renal pelvis also appears a bit to be pushed downwards. Maybe there could
Yes.
be
And the
upper moiety
size?
obstruction. The size is smaller than the left.
Yes. Okay. You don't see the upper part at all. See, it's just this size alone, something not right. See, if you look at the kidney, that's the size of the kidney. See the kidney outline going all the way up there. So there is an upper moiety there that is so badly obstructed that it's not excreting at all, right? So if ever you suspect that, what examination would you do?
Do an ultrasound KV?
Yes, it will be excellent. It will show you the duplex and a markedly hydronephrotic upper moiety. It will tell you the hydronephrotic left upper moiety and also show you the urethral seal. Okay?
Okay, thank you for that too.
Okay, come next.
Hello, good evening. I'm Jason here from USM. May I begin?
Yeah.
So I'm presented with a frontal chest radiograph of an adult patient. There is a fairly homogeneous, this is a homogeneous opacity seen within the, occupying the entire left hemithorax. And there's absence of air bronchogram seen within, and then the left bronchus is also seen cut off within this opacity. A hazy opacity is also seen within the right mediastinum region with loss of the normal right hilar point. There is elevation of the left hemidiaphragm. There is no right pleural effusion. There's deviation of the left trachea to the left side. And then there is the rest of the bone and soft tissue are normal. So my diagnosis for this is a complete whiteout of the left hemithorax. Possible differential, it could be a obstructing mass, obstructing the left main bronchus. Could be my first differential would be a left bronchogenic carcinoma. Differential would be
What else can it be? So is there loss of volume in the left lung?
Yes.
The left hemithorax loss of volume. What can cause loss of volume? You say collapse, yes, what else?
Collapse. You can also be a massive consolidation, severe pneumonia. Loss. Sorry, Prof. I want to add that there's an absence of a rib actually.
Yes. Okay. Yeah. Now you're getting warm. Okay. So what is this due to?
This can be due to because this is a posterior rib that's missing. So it could be a posterior mediastinal, posterior mass actually.
Oh, no. What else? What else? A rib missing there means what else can it be? So what else can cause the loss of volume?
Oh, it can be pneumectomy, pneumonectomy.
Yes. Okay. So this is a pneumonectomy. So if suspects pneumonectomy, you can ask the examiner whether this patient has had a pneumonectomy, and they'll say yes. Okay. All right. So this patient has a pneumonectomy, right? So what else you notice on the right side?
There is widening of the right mediastinum with a like consolidation, central consolidation.
Yes. What can do that?
So you can see this in infection.
So this patient had a pneumonectomy, likely due to what?
Most likely due to malignancy, and they have to remove the entire lung.
Okay, fine. So now you see this opacity on the right side of the mediastinum. So what are the possibilities here?
It could be a metastasis from the malignancy.
Metastasis where?
To the right hilar region.
Right.
Maybe the right hilar region.
Okay, metastasis into what? What is it?
Hilar lymph nodes.
Yes. Okay. Yes. Hilar lymph nodes. Yes.
It could be intrapulmonary within the round parenchyma as well, but these findings also can be consistent with radiation therapy if it's even radiation at the region.
Yes. So what is the clue? Why did you say it's radiation? Can be a radiation?
Because it appears almost linear, straight. is uniformly affecting the right mediastinum region.
Yes, because it's a straight line here. See, a straight line there. So that is conforms to a mediastinal port, radiation port. You see. So if you're not sure, what will you do?
Not sure. I can compare with previous radiograph.
Yes, of course. You compare the previous radiograph and looks the same, then you know what it is. Okay? Right? Okay, so this is actually a patient had a left pneumonectomy with post-radiation change in the mediastinum, all right? So you may want to think of metastases or lymph nodes or whatever else, but a differential diagnosis you need to consider will be radiation. And the way to prove that is either get a history or you want to compare with previous
chest
radiograph. Yeah, to see if there's changed or not. Okay? All right. So remember, if you see this appearance with one rib missing, patient has had a pneumonectomy. Okay. So complete white out a few things. If this is a huge effusion, then you get mediastinal shift, right? You won't get loss of volume like this. Okay, so time now. Okay, we've got 6. Maybe we just do one more and then we can stop. No, this. Okay, come.
Hi, Doctor. This is Carmen from UM.
Yeah.
Okay. This is a chest radiograph of an adult. So, I can see that the cardiac contour appears enlarged, suggestive of cardiomegaly. There is also thickened left para-aortic line, which appears to have double contour. I can with varying density. Otherwise, the hilar vessels are still preserved bilaterally. There's no suspicious lesion seen in both lung fields. Otherwise, there's no any suspicious bone lesion. So I cannot really visualize the vertebra, but I can still see the left paraspinal line. So
Okay,
in
the
this
heart
case,
is, so now you know the heart is enlarged. What are
yes.
the possible causes of enlarged heart?
So in an adult, could be first could be congenital, but probably less likely in an adult. Another thing is heart failure. I do not see any pulmonary edema changes. And also I'm thinking of the possibility of pulmonary arterial hypertension as well. However, there's no, the bilateral hilars are quite clear. There's no lobularity seen. I don't see any prostatic valve.
Okay, Chapman says five. Chapman says 5 causes of large heart, right? Congestive cardiac failure, cardiomyopathies, valvular heart disease. What else? Epstein anomaly. And what's the other one? There are 5. Okay, So which one is this?
Okay, on the second look, I think the carina appears slightly splayed.
Okay.
Then I can see there's double heart contour on the right side. I think
Yes.
it's a double density sign. This is
Yes.
suggestive of a left atrial enlargement.
And what other sign of atrial enlargement do you see?
For the left atrial enlargement, so splaying of carina and also double density sign.
What is this?
Oh, there is enlarged left atrial appendage.
Yes, okay. So all this points towards an enlarged left atrium, okay?
Yes.
And what's the commonest cause of that?
For left atrial enlargement, the most common cause in an adult would be mitral stenosis.
Stenosis. But is the left ventricle enlarged as well?
Left ventricle, in mitral stenosis.
No, in this patient.
I think yes.
Yeah, it has to be
Yeah.
because the whole transverse diameter is dilated, right?
Yes,
It's
yes. So
enlarged,
both,
right? The
both the
atrium
left
itself won't
atrium,
cause this. Yes, so it's mixed mitral valve disease, not just atrial, not just mitral stenosis, it's
mitral
mitral
regurgitation.
also. Okay, fine, right? So you heard of the moguls, right? The 4 moguls?
Yeah. Yes.
Yeah. So this number?
3, the third.
Yeah, third one. Now then the fourth one we left ventricle. Now they're talking about the fifth one, which is this cardiophrenic angle. If there's something else that is bulging out here, maybe a pericardial fat pad or pericardial cyst or something. Okay, but typically there's 4. All right. So in the exam, sometimes you may be given a big heart, not so common, and it either due to valvular heart disease, which you may be able to pick up, or maybe due to pericardial effusion. Okay, that's another thing. Pulmonary arterial hypertension seldom presents with gross cardiomegaly, seldom, all right? Because you, in that case, you usually get a right heart enlargement, right? Not the left heart enlargement.
Yeah.
So what's your next sentence will be for this?
I would like to suggest for echo assessment.
Yes, okay. Don't stop at the teacher. That's the next thing you will do, all right?
Thank you, Dato'.
Okay, we'll stop here. I'll have a good long holiday and then get back to the exam again. Okay.
Okay, thank you, Dato'.
Just a moment. Just a moment. I need to check something. Now you have, let's see, now 17. You got 24th, 31st, 7th, 14th, 21st. So you got another 5 more weeks. The 28th week, and then after that is your exam, right? You all look at your calendars. The whole of April. The first week of May is your exam, right?
Yep.
Starting on the 4th, is it?
We're starting on
27 April.
27.
Or 27 April is your theories.
Yes.
Yeah.
Okay, so the last weekend, the last Tuesday before that is 21st.
Yeah, yes.
You're okay to have class or you all want to skip that and study? Anyway, you let me know. So at least we got 1, 2, 3, 4 more weeks. If including the 21st is 5. So I'll try and finish off in the next 4 weeks. If you all okay, can have maybe 1 more on the 21st, okay? And then let's see, your Viva is when? The week?
Viva on 6 May.
That is on a Wednesday, right?
Wednesday, yes.
Okay, so Tuesday, you all excited to have a class or no? Anyway, let me know. Let me know. We can organize something, maybe a revision or something like that. Okay. Okay then. Bye.
Thank you.
Bye. Thank you.
Okay, bye.
Thank you.